Hello everyone, welcome to the CRE HiPP Showcase event for 2021. Thrilled to have you all with us. Thank you so much for registering. We have over 150 people who have registered with us today, and we thank every single one of you for your interest in CRE HiPP that we know is funded by the National Health and Medical Research Council. It's based at Monash University and in partnership also with Monash Health at Monash University. I would like to begin by acknowledging the traditional owners of the lands on which we all meet today. These lands always were and always will be Aboriginal land. I am meeting on the lands of the Bunurong people of the Kulin Nations and pay my respects to elders past and present, and acknowledge any Aboriginal people that are with us today, as well as our valued consumer representative, Louisa Wesham. I am Professor Helen Schoenaker, the Director and Lead of CRE HiPP. Of course, CRE HiPP constitutes 10 Chief Investigators and 10 Associate Investigators. Our fabulous consumer and community advisory group, I'll tell you about them later, and a vast array of early and mid-career and PhD students. So I thank every single one of them for the collaboration, the dedication to CRE HiPP, because it's genuinely a team effort. Our agenda, I'm so thrilled to be presenting this agenda to you today. It's 2 hours and 15 minutes, but it's jam-packed with fabulous presentations. I'll give you a brief overview of CRE HiPP, and then we'll move to our keynote speaker, Adrian Gordon, then on to Jacqui Boyle, and then on to Ruth Walker, Danielle Schoenaker, Fiona McAuliffe will finish us off with our last keynote presentation, and Jacqui Boyle will come back to sum up the showcase event for you. So CRE HiPP aims to refine and implement health promotion, lifestyle improvement and obesity prevention, strategically targeting women preconception and during pregnancy to improve the health of women and the next generation. CRE HiPP will generate new knowledge, and it will generate new knowledge across preconception and pregnancy and cultural adaptations in those life phases. It will translate this new knowledge into policy and practice. It will develop a multidisciplinary research workforce, and it will leverage our extensive existing multidisciplinary collaborations. Of course, we're already doing all of that, but we still have another 3 full years of CRE HiPP. Generating new knowledge. Preconception. Now, the theme today is preconception, so I'm not going to tell you a lot about preconception because Jacqui's leading our preconception theme, Jacqui Boyle, and she will obviously be presenting, as will Ruth Walker and others. CRE HiPP PhD stipend for project on lifestyle and infertility is being led by Lisa Moran, who is a chief investigator on CRE HiPP, and Lisa will be doing that work starting next year. This is a project that Shona Madden, our PhD student, is conducting with Bryony Hill, Andrew Hills, Kieran Ahuja, Claire Blewett and myself. And it's all about developing a workplace HiPP portal, the first of its kind worldwide. We don't know of any other workplace portal that's been designed to promote health in preconception, during pregnancy and post-birth, interconception between pregnancies. So this is really innovative. Shona has done an amazing job in her PhD. We're very proud of her. She has developed an implementation toolkit working with industry partners at UniTAS and at McAuliffe Family Services. And the workplace portal is unique and based on the needs of the employee and the organisation. We have co-designed the contents. It's about what their employees need for this very important time. And that's why they're loving it and they want to implement it and scale it up across their organisations, which is terrific. Aboriginal and Torres Strait Islander work is being led by Louise Maple-Brown, an associate investigator on our CRE HiPP, and Jacqui Boyle, and they are working to improve lifestyle health outcomes in preconception, pregnancy, and into conception for Aboriginal and Torres Strait Islander people, with a specific focus on women who have diabetes. And that work's being conducted in the Northern Territory, with community in the Northern Territory. In pregnancy, we have lead Cherise Harrison and Helena Teed. Cherise is one of our postdoctoral fellows working in CRE HiPP, a senior postdoctoral fellow, and Helena Teed is CIB on CRE HiPP. They have obtained multiple additional grants to deliver this work in pregnancy. They have conducted extensive evidence synthesis, and there is a meta-analysis, which is really exciting, that many of us are on, that Helena and Kate Bailey have led as first authors, and Cherise Harrison is the senior author, and that will be coming out in JAMA International Medicine this year. It's been accepted. That's really exciting. Policy stakeholders have been engaged. National pregnancy guidelines are being updated. That's an MRFF-funded initiative. Multiple large-scale national, international implementation trials are completed and underway in both public and private healthcare sectors, and implementation toolkit development. Other pregnancy work led by myself and Jacqui Boyle involves Aboriginal and Torres Strait Islander work. We have been part of the Australian Anti-Racism and Perinatal Practice Alliance that has been formed this year and led by Dr. Rochelle Hine from Monash, who are mentoring 19 members to date. And Rochelle has led a fabulous perspective piece on identifying and dismantling racism in antenatal perinatal settings, reframing the narrative from a risk lens to internationally prioritise connectedness and strengths in providing care to First Nations families. There is also a new PhD student starting in this area, Kelly from the Australian College of Midwifery, and personal reflections of lifestyle health in pregnancy from Aboriginal women, led by our consumer representative, Louisa Wetton. Another area of pregnancy that we're pioneering is growing queer families, ensuring our CRE is inclusive of all women and people who experience pregnancy. We have a celebration video coming up, and there will be evidence-based information, supports and resources for and with the LGBTQA+ community. We are developing up a position paper that we will put out to policy and organisations across the country, and we have been invited to contribute to a special edition in midwifery and linking with colleagues in the UK to do that. So that's a really exciting space. Translating new knowledge into policy and practice. We have very different layers, multi-layered translation strategy. We have a knowledge synthesis hub, and we at the moment are also uploading bites, brokering innovation through evidence. They're bite-sized pieces of information that summarise the work that we're doing. So please do go to our website and be updated with the bites. Training and mentoring, that's led by Andrew Hills and Kieran Ahuja. We have provided lots of small grants to fabulous teams across the country. This one is led by the Sunshine Coast of University, this one by the Burnett, this one by Central Queensland University, this one by Monash University, and this one by Newcastle. And we are proud of all our early and mid-career researchers who applied for grant funding and have been doing seeding grants in the area of health in preconception and pregnancy. Again, all the information is on our website. I'm most proud of this, the Health in Preconception, Pregnancy and Postpartum Early and Mid-Career Researcher Collective. It's a collective that this year has been led by Vanessa Shrewsbury, but has been in the past led by Bryony Hill and Heidi Bergmeyer. There are over 60 members to date. They have a published paper already. They ran a fantastic conference last year. It was the second one for them, with over 115 registrants and 33 presentations. And they are expanding internationally. So they are moving and shaking amazing. Our Consumer Advisory Group, a lovely way to finish off this presentation, is led by our Consumer Advocate Coordinator, Sian Ratchik. And I'm not going to go through their bios. Again, they're on our website. But we have Razia Ali, we have Jacqueline Bowden, Tatiana Corrales, Zoe Jacks, Jacinta Cracker, Georgia McLaughlin, Eva Moore, Yvonne Sun, Jasmine Taylor, and Louisa Wetham. And we are completely indebted and thankful for their support, their commitment to CRE HiPP. Watch this space. They're also developing a fabulous video to talk about their own experiences as consumers with lived experience. So we will distribute that as soon as it is ready. So now, without further ado, I move on to our keynote speaker, our first keynote speaker, who is Professor Adrienne Gordon. Adrienne will be talking about the potential of preconception weight loss to improve pregnancy outcomes for women with overweight and obesity. I'm just going to stop sharing so Adrienne can share. Is that okay, Adrienne?
Yep, fantastic.
Fantastic.
Let me just, make sure it's all working. And
now, I wasn't going to introduce you, Adrienne, so you can use all the time, because there is a complete bio of Adrienne on the presenters list that we distributed. And I'm sure you all know who Adrienne is, a fantastic person and a fantastic researcher and expert, obviously a member of a CRE stillbirth. So we are so thrilled to have you with us, Adrienne. Thank you very much.
So Helen, I don't know if you can hear me, but my computer's just completely frozen up here.
Oh, has it? Do you want me to share? Would you like me to share your presentation?
The issue is I won't be able to see it because mine has just. I'll just start again. I think it might just be hospital internet.
Sure.
So
we can wait.
If I just start again, it should hopefully work. Okay. Can you hear me now?
I can hear you. Are you okay to go?
I'm okay to go.
All right, fantastic.
I'm hoping that the hospital internet will stay.
Yeah. So are you okay to share your screen?
Yes, I thought I was sharing my screen.
I can't see your presentation yet.
Great. Okay. Fantastic. I must have done this how many times? Okay. Can you see that? No.
No.
Okay. Start here again, share.
Okay, people are saying they can see it, so you go ahead.
Okay, fantastic. Yeah. All right, well, thank you so very much, Helen, and the CRE HiPP team for the invitation. I'm delighted to be here this afternoon and to share some recently published data and a new trial from our collaborative team up in Sydney, who are based at the Charles Perkins Centre. So I'm going to talk about the potential of preconception weight loss to improve pregnancy outcomes for women with overweight and obesity. So we know that the world is getting larger, and we know that since about 2007, we now have more people in the world with obesity than who are underweight. That obviously affects all adults, but we are particularly interested in women of reproductive age. You can see this map from the Lancet from some time ago just actually shows the prevalence of obesity across the world for women of reproductive age. And so in Australia and in many other very similar settings, every second woman will begin pregnancy having overweight or obesity. For Australia, this affects 14 million of us, and by 2025, which is coming up pretty soon, close to 80% of all adults, potentially a third of our children, will have overweight or obesity. It's overtaken smoking as the leading cause of premature death and illness. And of course, from our point of view, in this setting, we're really interested in how that impacts on maternity outcomes. So just by way of background, this nice paper from Sydney just looks at the population attributable risk for important perinatal outcomes over this period, 1990 to 2014. You can't get really great national data on this because weight fell off the perinatal routine data collection for some years. So that's why this is from a health district. If you look at the data, complete data here for about 43,000 women, you can see that the prevalence of overweight and obesity by different class has increased over time from the 90s to 2015. And with that, so has the population attributable risk for these important outcomes. I'm particularly interested in adverse outcome like stillbirth and also premature birth and whether babies are admitted to the nursery. All of those things have increased. For stillbirth, the population attributable risk is about 7% in the latest time epoch. And of course, overweight and obesity in mums affects the size of babies. So if you compare the number or the prevalence of babies who are large for gestational age across different groups of maternal BMI, that is overrepresented with a higher maternal BMI. But also if you compare against international standards such as Intergrowth 21, there is a higher than expected prevalence. This is important because it impacts on this intergenerational cycle that can lead to lifelong complications. And we know that if you follow people through life, and this great data from the Aberdeen data bank in Scotland shows that if you look at cause of cardiovascular death over life, and you look at the maternal BMI, that there is a relationship all the way through life. So an earlier risk of having a cardiovascular death if your mother entered into pregnancy in the overweight or obese range. So do interventions pre-conception in women with overweight and obesity actually work? Well, the first place we would normally go to look for this information is somewhere like the Cochrane Library. Is there high-level evidence of what we should do as clinicians in this area? And this is very much due for an update, and I'll take you through some of the trials, but the last systematic review publication is still from 2015. At that time, in terms of directed pre-pregnancy programs for women in this BMI category, there were no trials. So no conclusions to inform practice, more understanding needed. Obviously a lot of clinical guidelines stating that being a healthy weight or considering weight loss prior to or in between pregnancies was available, but no actual clinical trial data. So definitely an evidence practice gap. So if we look at trials in the area that might not have yet made it into that systematic review, this is a review of weight loss interventions for both women and men, although mainly women, and they looked at both randomized controlled trials and observational studies. So there were 40 studies included here from mid-60s to 2016, but 14 of them were randomized trials. They used different interventions. The majority of them were a combination of diet and exercise. They only looked at short-term outcomes, and many of them just looked at pregnancy or natural conceptions. Not all of them looked at live births. You can see there a higher likelihood of achieving a pregnancy that was statistically significant from those randomized trials, and a sort of trend to significance for live births and natural conceptions wasn't measured in all the trials. And the largest study in this space was published in the New England Journal in 2016, so largest in terms of numbers. This included just under 600 women who were receiving fertility treatment in the Netherlands. They were randomized to quite an intensive 6-month lifestyle program in terms of support for diet and exercise. They were advised to delay their fertility treatment, and you can see here that their outcome was live births. Now, in the intervention arm, there were less live births than there were in the control arm. And if we just remember that those in the intervention arm had a delay in starting their fertility treatment. So if you drill down a little bit more into some of their results, you can see that in terms of the method of conception, if you were in the intervention group, you were statistically more likely to have a natural conception, but in the intention to treat analysis for overall outcomes, as we saw, you had less live births in that intervention arm. So what about thinking about pre-pregnancy as between pregnancies or before the next pregnancy? So this review that was led by Jodie Dodd looked at that postpartum period to promote weight loss and brought together those trials. So 27 trials included in this review, just under 5,000 women. And again, not all of them had outcome data. Most of them just reported on weight change alone. And a smaller number of them looked at weight change and a little bit longer, so a year after. Most of them were in the US, but there were 2 in Australia. And this is what they found. So really, they found on average a weight loss of about 2.5 kilos, slightly larger if people had overweight and obesity. And the studies that did follow up for a year found that that smallish amount of weight loss was maintained. More closer to home, this is a pre-pregnancy weight loss trial from Melbourne, from Michael Permisel and his team. And this is the POP study. They were interested, very similar to the trial I'm going to present, in the use of meal replacements to improve outcomes. And the first study that they have actually published by Sarah Price was actually a sub-study just looking at time to pregnancy. So their main outcome for this trial was a composite outcome, 2 primary composite outcomes, 1 maternal and 1 perinatal. So they looked at time to pregnancy here. SDI is standard dietary advice, VLAD, very low energy diet. You can see that people who had the intervention, so the very low energy diet, seemed to get pregnant more quickly. This other study, also recently published just about a year and a half ago, is called Prepare. This is from the Kaiser Permanente network in the US. They looked at women who are planning pregnancy with a BMI of 27 or above. Their intervention was a coaching session. They set up a website. They got people to follow the DASH diet, which is known to be useful for those with hypertension. They got them to monitor and count calories. They had phone coaching until 6 months. That was every week. And then they continued that monthly till 18 months or until the end of a pregnancy. So again, quite an intensive lifestyle intervention. Those in the control arm just got a sort of short group session of 5 to 10 minutes and then usual care. And their primary outcome was whether you exceeded gestational weight gain guidelines. You can see here about 160 people followed through to the end of this study. So in all of these studies, you end up randomizing more people than are left at the end, because obviously not everybody will achieve a pregnancy. This is the primary outcome for Prepare. You can see here that in the intervention group compared to the usual care group, the first trimester was pretty much identical, and maybe a slight difference seen by the 3rd trimester, with the intervention group having slightly more exceeding gestational weight gain. But overall, all of these odds ratios cross 1 and no significant differences for this primary outcome. But when you look at when women regained weight after their intervention, you can see that many started a pregnancy in a lower weight range, but they did tend to catch up. And that seemed to be particularly in the 2nd and 3rd trimesters. It was also affected by how quickly people became pregnant after the intervention, which I guess makes sense. So those who became pregnant quite quickly, they didn't have as many differences. And those who became pregnant 2 years later actually started a pregnancy in a higher weight range. So timing and follow-up and timing of pregnancy and return to weight is really important for these trials. So I'm now going to tell you about our pilot trial and what we're planning to do next. And then in the questions you can tell me if there's any other really important things that we should be doing in this larger trial as we're just commencing. So prior to doing our pilot trial, we did some planning with consumers, which was really important. So we did some research prioritization. Our highest ranked research question in intergenerational obesity was about pre or inter-pregnancy weight loss and outcomes. We surveyed just under 700 reproductive age women, and just under 500 were pre-conception. 187 had a BMI of 25 or above, and 75% of those said they would join a program, they would want some personalised support, they would like it to be online, and a favoured time period of somewhere between 8 and 12 weeks. So we used that information and some pilot information about the intervention, which I'll explain to you shortly, to go and design this pilot trial called Prebabe that was just published relatively recently in Nutrients. So our aim was really to determine whether a partial meal replacement diet program in women with overweight or obesity was actually feasible to do. Could we recruit women? Did they like it? Was it acceptable to them who were planning pregnancy? Reproductive age women, but with a cutoff of 40 years, just because of the the reduced incidence of pregnancy with age, planning for pregnancy within the next 6 to 12 months, and planning to birth at the recruitment site. We had a range of exclusion criteria that might contraindicate rapid weight loss, and obviously if they were unable to provide consent. It was an individually randomised trial. We had study visits one morning a week embedded into an existing pre-pregnancy service. We didn't have very much money for this pilot, so we had some very low-tech recruitment and pavement pounding and attending playgroups and pharmacies, daycare centres, a little bit of paid advertising via Facebook, central allocation stratified by BMI. So this is the intervention we used. This is a partial meal replacement program that's been designed by the CSIRO. They had run a randomised controlled trial of adults the year before and had shared the data for reproductive aged women with us. In that group, there was an average weight loss at the 12-week point of around 10 to 11 kilos. They had some blood tests showing safety in that population, so we were quite happy with that pilot data. It is commercially available in pharmacies. Each day there is a meal plan. Every day there's some real food, and there's some intermittent energy restriction on alternate days, which then allows a participant to have 1 day per week where they don't have any meal replacements at all. Our control was recommended diet and exercise advice according to national guidelines, but we did offer a referral to the free telephone-based health coaching service in New South Wales called Get Healthy, because that is a sort of recommended standard of care in clinical settings in our state. So we felt we couldn't do nothing in this control arm, and we offered this referral. This is our consort. We assessed 132 for eligibility, randomised 50 women into the study. So 26 were on the meal replacement arm and 24 in advice. The retention was a little bit greater on the meal replacement arm. You can see at 12 months we ended up with 12 pregnancies in the meal replacement arm and 4 in the dietary advice arm, but this is a feasibility study, so not powered at all on this outcome. These are our baseline results. So most women were sort of early to mid-30s. The average weight was about 90 kilos. We had a fairly educated group in this study, slightly more primiparous women than there would be in the general population, which would be about sort of 45, so slightly more in a first pregnancy. And we had quite a high rate of people who'd had a previous pregnancy loss, so obviously quite a motivated group that signed up to this trial. We wanted to look at what weight loss might occur in the 2 different arms. It was not powered for weight loss, it was a feasibility study, but we did find a significant difference in the percentage of weight lost from baseline to week 10 in the meal replacement arm. But you can see there is some overlap there that's just statistically significant, but that has helped us with our sample size creation for our larger study. We also asked our participants, what did they think about the study? Did they get enough support? Did the program suit their needs? Oh, sorry, it's gone back to our little first baby here. I'll just go back. Did the program meet their needs? Would they recommend it to a friend? And could they have done this with no face-to-face? So we had a combination of face-to-face and online. And pre-COVID, we were still very interested in, you know, could we run this completely without face-to-face support? But there was definitely a large number that felt that face-to-face plus the online support was important. This is the first baby that was born from women in the trial. So the conclusions from our pilot is that the partial meal replacement program with a bit of online support was feasible. It seemed to result in more weight loss than standard advice or phone counselling. And so for this sort of program, it might be more acceptable to women in this age group compared to the free services currently available. So we've now used that information and have some funding from the MRFF to run a larger study. We've called this the Prebabe Trial. That's our website there, prebabe.com.au. But our aim now is really to look at perinatal outcomes and cost effectiveness. So this is a much larger study. It has a composite outcome, and I'll come to that and go through it. But we're estimating a 20% relative risk reduction in that composite outcome. That would mean we need just under 900 babies, but we have to, in such a study, inflate for whether people become pregnant, whether they have a live birth, and whether they adhere to the protocol. So bearing all of that in mind, we are planning to recruit 19,027 women who are planning pregnancy. This is our primary composite outcome. I'm not a huge fan of composite outcomes, but very difficult to run such a study without the use of a composite outcome unless you have sort of tens of millions of dollars. So you can see there we've got 3 maternal, gestational diabetes, preeclampsia and first caesarean section, and then perinatal death, large for gestational age or being admitted to the nursery. We're looking at a host of routinely collected data as well, and we have funding for data linkage going forward so we can follow up people in this trial in a low-cost way throughout the first years of life. We've got 5 sites on board at present. They're all sites that offer some form of pre-pregnancy service so that we can embed this trial into clinical care, and so that if any referrals or consultations are required, that can happen. So we're also linked through those sites to things like health pathways and the primary health networks, and some of these services are within a kind of women and babies model, some of them within a family metabolic service. We're going to be recruiting on social media with some paid ads in a paid ad campaign. This is just a bit of a selection, and we're actually having a launch just after Christmas, so we can maybe capitalize on post-holiday New Year's resolutions for women that might be interested in weight loss and planning for a baby. So the take-home messages are, I think we'd all agree in this forum that pre-pregnancy obesity is definitely a public health issue. We do have guidelines supporting weight loss, but we don't have hard trial evidence to back up what to do or for primary care physicians to refer people into. Australian trials are coming, and ours is one of them, and we'd love your support and shared advertising when that commences. And we do think that something that is commercially available but can be supported by health services would be translatable, and it's a huge opportunity to not only improve pregnancy outcomes but potentially maternal and child health outcomes long term. And I'd like to acknowledge a whole host of people who have been involved in the design of the study and in the pilot work, and very excited to answer any questions.
Thank you so much, Adrienne. That was fabulous. I really enjoyed it. I know I've had some text messages from people telling me how brilliant you were. So Adrian, a specialist neonatologist, as we heard there, in the RPA Centre for Newborn Care, and clinical professor in the discipline of obstetrics, gynecology and neonatology. What a brilliant talk, and also part of NHMRC Stillbirth Centre of Research Excellence. So thank you so much, Adrian. Really appreciate it. Any questions from the audience? Please post your questions and we can ask Adrian to answer them. Yes. I saw Emily had raised her hand. Let's have a look. Allowed to talk. Okay, Emily, you can talk.
Just wondering if I can recruit in Melbourne, Adrian.
Well, you know, we have set this up in New South Wales because of the control arm, but I think we will need to explore expansion, and I know that different jurisdictions have kind of got a version of the Get Healthy service. So at present, not yet, but I think we will be exploring that in the future, definitely.
Okay.
Thank you. Thank you, Emily. Anyone else? We have Stephanie. What do you see as the sustainable model for this project, that GPs recommend women use MRT and online counselling, or that the government embeds it in their phone counselling? Thank you, Stephanie.
Yes, so Stephanie, that is a great question, and because we've been collaborating with the Department of Health, because Get Healthy is the control arm, we have been asking some of these questions in both the grant application and in the kind of initial setup. Look, I think at the moment it could be either of those things, but in reality it's probably going to end up coming back to primary care, and potentially that there is some health fund subsidy for women to actually be able to use meal replacements if that is recommended by their primary healthcare practitioner. So for example, in the NHS, you're able to access this if you have a BMI over 27, and here you can get a Medicare rebate if you have comorbidities. So I think if we prove that this is useful, then we will have to have a translatable model of doing that. But I think leaving it to be managed through something like the Get Healthy service might not be sustainable within the Department of Health. I think you need primary care, you need some clinical setup to do the support. So yes, I think that's probably where we'd be, but it's a very good question.
Thank you, Adrienne. And Bree asks, do you screen for reasons why a woman might be overweight or obese before suggesting weight loss, so the reasons unrelated to energy intake are addressed?
Yeah, so that's an excellent question as well. So we do some validated scales of depression, anxiety, social support, but we're not using it as a, you know, if you score this, you're not eligible. We're not using it in that way. We're using it to see if there is any improvement and to see if there's any way that people might need some additional support. And because they're in a clinical service having this trial, we'll be able to refer for additional support. So again, I think it's an excellent question. I know there's been many weight loss trials that screen to see whether you will actually engage in a weight loss trial or not, and obviously show more success if you say that a certain group of people are ineligible. But we really wanted to make this as pragmatic as possible. So we're collecting the data, but we're not using it to screen you out.
Thank you, Adrienne. Well, that's terrific. We've got another question from Amy Steele, so we're going to sneak this one in, Adrienne. How much data are you collecting about male reproductive partners?
Yep, so
that's great.
That's a great question too.
Yeah.
We've had various groups wanting to collaborate about the male partners. At the moment, we're collecting very little, I'm afraid, and I think that was, you know, even in studies in pregnancy, so not pre-pregnancy, studies in pregnancy that look at things like blood group incompatibility, there is a surprisingly large rate of non-paternity. So I think as the chief investigator for this project, I just couldn't quite get my head around the fact that many of these partners might not end up eventually being the father, and we'd be collecting a lot of information. So I think it's really important, but we haven't worked out the best way to do that to make it accurate. If you've got any great ideas, please feel free to email me.
That's terrific. What a great way to end. Thank you so much, Adrienne. We really, really appreciate your time, your fabulous presentation. It was excellent. Thank you so much.
You're welcome.
From everyone at CRE HiPP. Thank you so much. And now I have the tremendous pleasure of presenting Associate Professor Jacqui Boyle, who, as I said, is a chief investigator on CRE HiPP and who is leading the preconception part of our CRE HiPP. So Jacqui, over to you. I'll do the same thing. I won't waste time introducing you, and then we'll talk later. Thank you so much.
Sure. Can you see my screen?
I can't, but I had that problem last time too. Are you sharing?
Thought I was. Can anyone else let me know?
Can anyone see the screen? Just let us know. All right, there's someone who says, no, can't see the presentation. So I'm pretty sure I've got the second screen up now, so I'll be able to tell you if I can see it.
Sorry, and
That's okay.
Can't even see it at all now. I've lost it off my... Oh, sorry.
That's okay, Jacqui. Do you want me to share?
Yes, thank you. Have you got the one I sent you today?
Yes. Yeah.
Sorry about that. I'm not quite sure what's happening. It's actually just disappeared.
I will share. No problem at all. Okay, so let's do this. And there you go, Jacqui. Just tell me when you want me to move it.
No worries. Yeah, thank you. Thanks very much, Adrian, too. I really enjoyed that talk. Just highlights all the complexities too, I think. I'd like to thank CRE HiPP for giving me the opportunity to speak today on the Preconception Health Network. Next slide, please, Helen. I'd also just like to start with an acknowledgement of country as well. So I'm coming to you from the Wurrung lands of the Kulin Nation as well. And I'd like to pay my respects to elders past, present and emerging, acknowledge that sovereignty was never ceded, and also acknowledge any Aboriginal and Torres Strait Islander people with us today. Thanks. So I'm just going to outline the background to why we've developed a preconception health network, talking about the importance of preconception health, planning for pregnancy and preconception health behaviours, some of the barriers to accessing preconception healthcare, and some of the opportunities to improve that we thought would benefit from having a network. Thanks. I'm sure most of you are aware of this, that preconception care is defined as any intervention provided to people of childbearing age, regardless of pregnancy status or desire, before pregnancy to improve health outcomes for women, newborn and children. And I've added in brackets there men, because I think it is important to recognise that we're trying to improve health outcomes for everyone. And that is, whilst our aim is to improve pregnancy outcomes and intergenerational health, we are also just, regardless of pregnancy outcomes, looking at improving health for everyone. Thank you. So there's a variety of recommendations really focused on what is perhaps modifiable by either health services or individual actions or policies. So these include planning a pregnancy, supplementation, so that includes things such as folic acid to decrease the risk of neural tube defects, vaccination updates, so particularly for example around measles, mumps, rubella, to prevent infection during pregnancy and again causing congenital anomalies, control of chronic disease such as diabetes, where we know that if you have poorly controlled diabetes, that your risk of congenital anomalies is also increased. It's an opportunity to stop smoking, alcohol and other drugs that will impact on a woman's health, but also that of the pregnancy. Giving time, as we've just said, it's very difficult and takes time to have a healthy weight. An opportunity to review medication that might be unsafe in pregnancy. Support healthy and safe relationships and support mental health. Thanks, Helen. So as you can see, they're very broad areas that really cross a lot of different fields of healthcare and also policy. So it is quite complex. Thank you. And I think it's always important to remember that it's not just individual knowledge, attitudes and health behaviours and health actions that are taken. We really have to think about this in the context of the interpersonal environment with families, friends and social networks, with organisations such as schools, workplaces, broader community, and then obviously under the umbrella of public and health national, both at national, state and more local levels, regulations, and things such as the built environment, pricing of food, accessibility, all of those sort of factors really come into play. So whilst a lot of our work focuses on the individual, it does really need to have a big picture overlying that. Thank you. Preconception health is a national, recognised national priority. So it's part of the National Women's Health Strategy. It's also a part of the Australian Health Research Alliance, Women's Health Research Translation and Impact Network. That's quite a mouthful. So they did some Delphi priority setting as well, and that was a key priority that came out of that workshop with a broad variety of people. Thank you. So who plans a pregnancy? It partly depends on who you're asking. It does vary by different groups. So between 50 and 74% of Australian women who've been surveyed have planned their pregnancy. And that's using, we've used validated measures like the London Measure of Unplanned Pregnancy. Thanks, Helen. And who has a pregnancy health check or undertakes recommended measures such as taking folate preconception? There's quite a few women who don't take any preconception health actions, and quite a large number will only take one health action. It is more likely if you've planned a pregnancy, but it's certainly not a guarantee. So there is opportunity to build awareness and change health behaviours in women who are planning pregnancies. It's more likely if women are Australian born, if they're older, and not surprisingly if they have private health insurance, because a lot of women will take out private health insurance when they're planning a pregnancy. Thanks. There are a number of barriers and facilitators for women. So women may not be planning, or as one participant said in a study, fully planning a pregnancy. They might perceive that they don't have a risk, and this is more common particularly in women who've had a previous uncomplicated pregnancy. A big factor is lack of awareness. Many studies have shown that women and men are really not aware of the importance of health behaviours before pregnancy. And certainly there is scope to improve that by looking at improving awareness, resources and education in schools, in families, in communities, and using social media and internet. Past pregnancy experiences, conversely, if you had an adverse past pregnancy experience, you may be more likely to have preconception health checks with your doctor. For many women, they don't see it as their doctor's role to talk to them about future pregnancies or planning a pregnancy. They see it as more of a natural thing, not a health issue. There are also social and cultural influences, which I'll just touch on in a minute. And women have consistently said that they often have other priorities that, apart from strictly health, and they include relationship stability, thinking about what's going to impact their child rearing, safety and education. So we also have to make sure, I think that comes back to that holistic approach. And one of the key facilitators, which I guess links back into that awareness and perceived risk, is believing in the benefits of preconception care and having it readily available. Thanks, Helen. Thanks, Helen. Just in terms of the social and cultural influences, we did do some qualitative work with the women from a variety of different cultural backgrounds, and I think those are just some of the things that we have to remember, that for some people it's just not talked about within their families or community. It can in fact be seen as something shameful. So we need to approach any interventions we do with care. And also some women have said that whilst they would trust their doctor to give them information, they didn't actually want their doctor to bring it up or ask them if they were planning a pregnancy, because they thought that would be weird. So I think when we're doing these, when we're implementing or we're doing research or implementing new services, we need to be very mindful of those issues. Thanks. What do primary healthcare providers think? That many of them do actually think it's their role, but they worry about bringing up the subject. They're not necessarily sure they know enough. They would like more education. They'd like resources for the people that they're seeing. They experience a lack of time. If you're a GP having a 15-minute consultation, it's very difficult to have the time to do a preconception health check and have a conversation about that. A lack of tools, lack of guidelines, and clearly you need good reimbursement, and whether that's for doctors or whether that's that's extended more broadly to, for example, practice nurses or nurse health practitioners. Thanks. And it's complicated and messy. It's not where you can do research and interventions in women who are pregnant, for example, because they're pregnant. Preconception and pregnancy planning is a big mishmash of everyone who is of reproductive age. So people may not be planning at all at one point in their lives, then they might be vaguely thinking about it, then they might be actively thinking about it, where they then move into that intenders group, and they might be actually trying to get pregnant. You have people who, I think it's really important to remember that there are some people who will never want children, and that's perfectly fine, but we still need to be really looking after their reproductive health. So we do need to have different interventions that really address these different life stages and also different times when people are intending or not intending a pregnancy. Thanks. So we saw that there were quite a few opportunities and that looking at it within that broader picture, that really we can improve healthcare with integration across research, policy, consumers, health and social care. And I think particularly social care, because when you listen, most of us will know that it's much easier to do research or surveys or trials with women who often are better educated or from higher socioeconomic groups and who speak English. So we really need to look at ways in which we can reach women who experience the most systemic discrimination and disadvantage. We thought that we could co-design priorities in healthcare and research, policies, guidelines, and putting evidence into practice. We thought a broader network would have more clout when it comes to advocacy, and that we can pull resources to develop resources and education for individuals at different stages and with different intentions. And as Adrienne was talking about before that, I think the life course issue of particularly unhealthy weight and other behaviours, that we really, in fact, need to also really be thinking about schools, and that's come up quite a lot in some of the work we've been doing. Thanks, Helen. So I'll just talk to you about the Health Network, who has been involved, what we've been doing so far. We're still quite new, we've only started this year. We've been doing some work in health and social care priority setting. We've done a review of guidelines and some of the future activities that we have planned, some of which are more ambitious than others. Thanks. So I've started this with Professor Kirsten Black from the University of Sydney, and the rest of our team has been Dr. Ruth Walker and Dr. Edwina Dorney, who have been amazing, and we've been very well supported by Professor Helen Skouteris and CRE HiPP. Thanks. We aimed initially to have meetings in every state and territory, but like everyone else, COVID got in the way. So we ended up having a launch this year where we invited people from all the major medical nursing societies and colleges. We invited consumers and community, people from policy, social care, healthcare, which was across primary care, but also including APNA as well as doctors, academia, some non-government organisations such as the Centre for Perinatal Excellence, which works with mental health. And we had a launch where we then discussed doing a priority setting workshop, looked at some terms of reference and some future plans. So the first activity that the group has undertaken is the priority setting, and I'll just talk you through what we did with that. Thanks. So we did a modified Delphi technique. We identified and ranked priorities for preconception care in Australia, and that was based on the review that I'll show you of Australia and New Zealand guidelines for preconception care. We developed some key strategies for addressing these and established a set of underpinning values to guide the future work. So the Delphi that we undertook, so we developed the priority areas, as I said, based on the guidelines. That was sent around as an online survey where people summarised and ranked the priorities. They also were free to add in anything that they thought that we had missed. We then had online discussion where we talked through the rankings, and we also talked through the new things that had been suggested. We combined some priorities, we put some into strategies and various other things, and then we sent it around again for people to again rank, and then we had our final result, which I will show you next. When we were asking people to do the priority setting, the things that we asked them to keep in mind was how common was the problem that they were looking to address. Is it potentially modifiable? Is it more relevant to particular priority groups than others? Does it have potential to improve health outcomes? Can it align with best practice? Does it fit with current policy? And did we think people would engage with it? And while addressing this problem, collaborative support the development of improved health systems and health outcomes. So that was the background that we gave them to when they were thinking about it. So what did we find? So very relevant to CRE HiPP, health behaviours, nutrition, physical activity and preconception supplementation were number one. Interestingly, there was a bit of quite a lot of discussion around whether healthy weight should be joined with that or whether it should in fact be separate. And in the end, we have left it separate. It was felt that it should be something that's not, that is quite broad and complex and needed to stand alone. Clearly, if you look at those, there is a lot of scope in those top ones for modifying healthcare and outcomes. And we think that it's a good place to start, and we'll be hoping to now look at some collaborative opportunities to focus on some of those top priorities going forward. Thanks, Helen. Some of the strategies that were suggested included public health and social care campaigns, health service reforms. This was quite, felt to be quite important. So looking at either Medicare item numbers for primary healthcare providers or even for, as I mentioned before, practice nurses, midwives, maternal and child health. So really trying to think a little bit differently to how we could help people to access care and resources. Preconception guidelines was considered to be quite important, as along with education of health professionals. Shaping health policy, acknowledging that digital technology could be a platform for healthcare, but also for education and health promotion, and raising awareness and providing education for the community and improving health literacy around preconception health. The underpinning values, the most important one we thought was community engagement, and I really loved the work that you did, Adrian, bringing in that community engagement in your research. Looking at a life course approach and not over-medicalising preconception health, recognising that that's not really what women and men want. So recognising it as a state of physical, emotional, mental and social wellbeing. Having an integrated multi-sectorial approach. Leveraging and strengthening large-scale national collaborations. Health equity and tailored solutions that incorporate diversity. So the last thing we want to do is increase disparity in health outcomes. Aboriginal and Torres Strait Islander health, whilst that could have gone in that previous group, we really felt that that was something that was important to be recognised as a standalone priority. And real world impact that encompasses clinical care policy and population health and includes measurable outcomes, which is often left off. And I think the fact that, for example, weight's not routinely collected now in pregnancy highlights the importance of good data. Also, thanks. So the other thing that we did was looking at clinical practice guidelines for preconception care, and this was led by Dr. Edwina Dorney. So initially we looked at Australia and New Zealand and subsequently internationally. So Australia and New Zealand we did before the Delphi, and then the international one we did afterwards. Thanks. So we did it because we know that evidence-based guidelines can assist in providing good quality care. And it has been shown at different times to improve outcomes, as highlighted there. And it certainly assisted in the development of our Delphi priorities. Thanks, Helen. So we did a systematic search and came up with 556 documents, of which you might be surprised to know that 96 were considered for appraisal. And we looked at them using the Agree2 tool, which is quite a well-known and validated tool for assessing clinical practice guidelines. So it looks at 23 aspects of guideline quality across 6 domains. And there are 2 overall assessments of guideline quality at the end, which ask what you rate the overall quality and would you recommend this guideline. And you can see that it's more about the process rather than the level of evidence that the Agree2 is looking at. Thanks. So these are the 6. Thanks, Helen. And greater than 80% is considered to be a high quality score, and while some of them scored well in some domains, none of them had an overall score that was greater than 80%. So we then moved on to do an international systematic review, and this included articles since 2008. They had to be in English, and they had to be national or international guidelines or recommendations that were focused on clinical care. Thanks. It's a very big process, as you saw in that previous slide, and I won't go through it except to let you know that there were 11 guidelines that we came out with in the end. One that was very high quality, that was how to manage women with HIV preconception. The other 10 were moderate quality, and there was very wide variation in, we also did evidence review in these ones, and there was a very wide variation in the levels of evidence around the guidelines and recommendations. So our conclusion was that there really isn't good quality guidelines for preconception healthcare. So our future activities, given all of that, we would like to develop some evidence-based guidelines, recognising that that requires a massive commitment, funding, and a lot of people, but we think that that's a good aim to have. It's certainly a strategy that was underpinning the Delphi, and there's a gap in the guidelines. We also want to look at clinical indicators and routine data, so we can look at monitoring outcomes. This has been done already in the UK, where they have got 66 clinical indicators, and they've mapped those to routinely collected databases around the country so that they can then map what's happening and what their response to different interventions is. In the USA, they've also done that, and they have 11 domains, and they have 45 measures. They're quite different in that, for example, the US doesn't include cervical screening and the UK does. But there are certainly a lot of similarities. So we are planning that will be one of our bodies of work. Will be looking at both the UK and the US clinical data indicators, looking at how that applies to Australia, and then looking at what routine data we have and mapping that to the clinical indicators. And then if there are significant gaps, looking at recommending that they should be collected and looking at how they could be collected. We have a number of international collaborations, including Danielle Schoenaker, who's talking this afternoon, and it's been really great to work with them, and they are going to be helping us with that clinical indicators. We also work a lot with, been working with Professor Brian Jack from the USA, who's very well known in preconception health over there, and the Global HiPP Alliance that was started a couple pre-COVID. We're very fortunate to have a meeting in Italy where everyone came together from around the globe to do some priority setting there as well. So if anyone is interested in joining, if any of that work sounds interesting, or you would just like to look at sharing your work more broadly and linking in with other people who are either in healthcare, social care, research or policy, please join us. And I would just like to finish by thanking the Preconception Health, everyone who's participated in the Preconception Health Network, CRE HiPP and Helen for her support, our international collaborators, consumers, and there's one more who'll be very embarrassed, Helen. Can you just click forward?
No, that's it.
Oh.
Yeah, that's it. Sorry, who was the next one?
That's all right. Sorry. I'm just going to say one final thing. I just really want to thank Ruth Walker, who's speaking next, because she has really been a driving force, keeping us all going and sticking to our timelines on what we're proposing to do on the Preconception Health Networks. Thank you, Ruth.
Fantastic. Thank you so much, Jacqui. Questions? Does anyone have any questions for Jacqui? I can't see if anyone's got their hand up. Let me have a look at the Q&A.
I might just also add that I think one of the important things that someone had mentioned earlier about males, we have had the Healthy Male group involved with the network, so we definitely recognise that I recognise the complexity of Adrian's work, but in terms of broader policy and interventions for men, we are engaging with the Healthy Male network.
Well, that's good to know. Any other questions? I'll just give people a minute. Okay, well, thank you so much, Jacqui. Really appreciate. You can be in touch with Jacqui to ask any questions that you might have of the Preconception Health Network. Jacqui is an academic obstetrician gynecologist, and so, as I said, a CRE chief investigator and you know, an expert obviously in preconception, pregnancy and interconception health. So thank you so much, Jacqui. That was a fabulous presentation, and we'll pass over to Ruth now. So Ruth, welcome.
Hi everyone.
Hello, hello.
Can everyone see me?
I can see you, and we'll launch straight into your presentation. I'll do it the same way for you as I've done for everybody, and then I can say a little bit about you later.
Can you
so
see
you
my
share? Yeah,
yep,
I can see that.
Cool, yeah. Can everyone see that okay?
Yeah.
Okay,
we can see that, Ruth.
Oh, wonderful. That's cool. I wasn't actually very confident that it was going to work. I'll just move that out of the way. Okay. Well, thank you all very much for the opportunity to present today. And to start with, I would like to acknowledge the traditional owners of the land where I'm presenting from, and that is the land of the Goodid Tamara people. And I'd like to pay my respects to their elders past, present and emerging. So the title of my presentation today is Co-designing a Sexual and Reproductive Health Curriculum to Promote Preconception Health in Young People. And I'd particularly like to acknowledge CRE HiPP and the seed funding that was awarded to this research earlier in the year. Without this support, this important work wouldn't have been possible. So this presentation relates to a body of work that has evolved over the past 2 years. It involves several studies with input from teachers, from health professionals, and importantly, young people. So this work is still in progress, and I'll just give you a brief overview of all the studies today. And towards the end of the presentation, I'll present some very raw data that we've collected just in the last couple of weeks with young people. So firstly, how did this work come about? So I've had the privilege of having many conversations with women over my years working within preconception health research and as a clinician. So I've been chatting with either participants or the patients who I see. And as I've had conversations about the importance of physical health and wellbeing in the preconception period, similar responses keep coming up. For example, they'll say, yeah, my preconception health is really important, and why didn't someone tell me about this earlier? And when I've discussed this with other clinicians, they tend to agree that they've had similar feedback from their patients. So the World Health Organization with UNICEF describes access to comprehensive sexual and reproductive health education as a human right, with providing young people with equal access to comprehensive sexuality education respects their right to the highest attainable standard of health, including safe, responsible and respectful sexual choices, free of coercion and violence, as well as their right to access the information that young people need for effective self-care. The World Health Organization advocates for sexual and reproductive health programs to be delivered by well-trained and supported teachers in school settings, as they provide an important opportunity to reach large numbers of young people. So if that's the case, why didn't someone tell us about this earlier? So in a qualitative study we conducted earlier this year, we explored health professionals' perspectives of sexual and reproductive health education in Australia and how this impacted on their practice. We also wanted to know what they thought about what the core components of a sexual and reproductive health curriculum should be. Now, I need to note that when we're working with school-aged people, we use the term sexual and reproductive health education as opposed to preconception health education, because we know that the term preconception doesn't really resonate with the general public, especially young people. And sexual and reproductive health education encompasses a few other aspects of preconception health that may not come up as often in preconception health specifically. So my warm-up question to our health professionals was, please describe your experience of sexual and reproductive health education when you're at school. So I'd like to ask you all to reflect on this same question now. What was your experience of sexual and reproductive health education when you're at primary school or high school? Now, I won't ask you to describe this in words today, but I'm wondering if you can rank your experience out of 10. So if you didn't learn very much, you might rank your experience as being a 1 or a 2. And if you thought it was pretty good, you might give it a 6 or a 7. And if you thought it was excellent, you might give it a 10 out of 10. I was actually going to ask people to pop their rank into the chat so we could all see the different ranks that people come up with, but I'm not actually sure that I'll be able to see your responses or that you'll be able to see each other's responses. So we might bypass that activity. But for our health professional participants, if they gave descriptive responses, but if I was to allocate a rank to their responses, I think most of the responses would have been, a 1 or a 2, and probably the highest response would have been a 5. So the personal experiences of sexual and reproductive health education for our health professional participants is minimal, but this was a really good opening question as it got them thinking about how important sexual and reproductive health education is for young people, but also for them in their practice. So last year we explored the question of sexual and reproductive health education in a systematic review of teachers' perspectives of the provision of sexual and reproductive health education internationally. And in this systematic review, we found that teachers thought that the provision of sexual and reproductive health education in and across schools is highly variable. So sometimes it's good and sometimes it's not so good. We found that teachers thought that the content provided was often inconsistent and sometimes incorrect, and it was often deemed as inadequate to meet the needs of students and young people. Teachers also described how what is provided is ultimately determined by school policy, the priority school leadership places on sexual and reproductive health, and the confidence and skills of teachers. And as a result, many young people are leaving school without an awareness of the importance of their sexual and reproductive health or how to protect it. So we also engaged with teachers in Australia on this topic. We conducted a national mixed method study of teachers' perspectives of sexual and reproductive health education in Australia. And I'm not going to go through all the detail of the methods in this study. The reference is there if you'd like to have a look at it a bit later, but I'm just going to pop straight to the results. So we had 189 teachers from all Australian states and territories who completed the online survey, and then we conducted in-depth interviews with 16 of these teachers. So the results were consistent with the systematic review, but they did paint a slightly more positive picture. And this is because our participants who volunteered their time were really passionate about sexual and reproductive health education for their students. We found that many teachers are actually well trained and confident to provide sexual and reproductive health education. And this is really good because it means it can be done well. We also found that teachers have access to a range of resources, including those from organisations like Family Planning Victoria or Shine South Australia, and even our state-based curriculum support materials. Barriers to providing sexual and reproductive health education included inadequate training, both at an undergraduate and postgraduate level. Busy schools and busy timetables is often a barrier for teaching any subject. We also found that a lack of priority based on sexual and reproductive health education by school leadership was also an issue. But a really important issue that was highlighted by our participants was that Year 11 and Year 12s often miss out on any formal sexual and reproductive health education. This is because the Australian curriculum only covers sexual and reproductive health specifically from prep or foundation up to Year 10. So this means that sexual and reproductive health education may actually stop at the age of 15 years for many students. So that finding has really set the scene for the work that we did this year with our health professionals and with young people. So just jumping back to our health professionals, when we discussed the issue of Year 11 and 12 students often missing out on sexual and reproductive health education, here were some of their responses. This one was from a school nurse. So our Year 11s and 12s make up probably 3/4 of the patients that we see with questions about those types of things. So I think that makes it pretty clear that it's needed. This one was taken from a midwife. People are turning 18 when they're in Year 12. It's actually in their personal experience of what's going on. So it's when it's actually going to stick and they're actually going to take it in. And this one was taken from a practice nurse. So I think it's a recipe for disaster. And that's in relation to many Year 11 and Year 12 students not having access to sexual and reproductive health education. So over the past month or so, we've been engaging with young people via an online survey, and then we followed that up with some workshops. And we asked young people about their experience of sexual and reproductive health education, particularly in Year 11 and 12. We also wanted to get to know what they think is important to include in a curriculum or to include in information specifically targeted at them, and also how we provide that information. So just sort of warming up in terms of the co-design. Now, I haven't quite finished analysing our data, but I'll give you an idea of what our young people were saying. So firstly, we had 1,118 young people aged between 16 and 21 years complete our online survey. Now, this was targeted just to young people in the state of Victoria. So of these participants, only 20 were male and 5 used a different term. So that means almost 90% of our participants were female. Of our participants, only 21% said that they felt like they left secondary school with enough knowledge about their sexual and reproductive health. 84% had received sexual and reproductive health education at some point in their secondary schooling. Of those 84%, 65 classified it as being not very engaging or very unengaging. 75% of our participants said that they did not learn about fertility, about sexual health screening, about family violence, gender identity, and sexuality at all. So those topics were not covered for 75% of our participants. And 95% of our participants said that not having access to sexual and reproductive health education during BCE is a problem. And sorry, BCE is sort of the Victorian version of Year 11 and 12. So thinking about what young people want to learn about, particularly at Year 11 and 12, these topics were reported the most. So respectful relationships, screening for sexual health conditions, fertility and infertility, and then also mental health. But our responses between our online survey and our workshops were slightly different. But having said that, I think the general feedback, particularly from our workshops, was that young people thought that all topics were really important and interrelated. And they also wanted, I guess, whatever is provided to them in year 11 and 12 to build on what they've learned throughout the other years of their schooling. So I'm just going to start to draw to a close now with a few quotes of what our young people were telling us in our workshops. So I think the overarching thing is that the current system is just so lacking that anything added would be an improvement. They've set us at quite a low bar. And this is another quote that broke my heart a little bit, but I've had similar messages from other participants in other studies, especially with endo or endometriosis. Like, I have that, and I feel like for so long I was like, what's wrong with me? I'm like, why didn't you tell me? I wish someone else would have said that when I was in year 12. And this is the last one. All my friends are like, you were so stupid. And I'm like, well, I never learned. Like, I didn't know. You can't call me stupid if I didn't learn about it. So I think it's really important. It just gives you a better ground to walk on when you go into uni or wherever you are going. So where to next? There has been a considerable amount of interest in this research from teachers, from health professionals and from young people. We've had a lot of feedback from these groups regarding how to provide sexual and reproductive health education to year 11 and 12 students. But the next logical step, I think, is to get these groups together to participate in meaningful and face-to-face co-design activities to develop what we know a little bit further and refine our approach a little bit more as well. We'll then need to test what we come up with in school settings and evaluate it as well. But I think another thing we also need to look at is how we can support teachers and schools to develop a whole school approach to optimising young people's sexual and reproductive health and overall health and wellbeing. And just finally, I'd like to acknowledge again CRE HiPP for their support, and also McAuliffe and the Faculty of Education, but specifically Associate Professor Jacqui Boyle and Associate Professor Danielle from the Faculty of Education, as they've sort of overseen this work and provided a lot of advice and expertise along the way, and also to our other people who have supported this project. So thank you very much.
Thank you so much, Ruth. That was a fantastic presentation. It's such interesting work and really, really needed. So thank you so much for pioneering that work. As you would all know, Ruth is a dietitian. She's also a secondary school teacher and a postdoctoral research fellow within the CRE HiPP, working with Jacqui on preconception health. So congratulations, Ruth. We've got time for one question. It's a really good one. Mitchell wanted to ask you a question about the interface of your research with the Respectful Relationships program in Victoria. Were any of the schools where the Respectful Relationships program run, were any of those schools better equipped to provide this education?
So I suppose recalling, because we certainly didn't get that sort of data from our most recent work with young people, but thinking back to the work that we did alongside teachers, Respectful Relationships as a resource came up quite a bit. And like I said, our participants in the research that we did with our teachers, they were all quite passionate and felt well equipped to provide sexual and reproductive health education, and were very happy with the resources that they had. But one thing that we did find that was for some teachers who were perhaps less trained or perhaps less confident, they'd sometimes grab bits and pieces of resources and perhaps not use them to their fullest advantage. So that's something that we need to keep in mind for teachers, that we give them the time to prepare and plan the implementation of the resources that are available to them.
Fantastic. Thank you so much, Ruth. Really appreciate your presentation today. And I will now hand over to the fabulous Dr. Danielle Schoenaker, all the way from the UK. What time is it, Danielle?
It is almost 5:30 in the morning now, so well, good morning from the UK.
You get the medal. You win. You're awarded the medal. So thank you so much, Danielle. Danielle will talk to us about the UK Preconception Partnership, normalising, improving and measuring preparation for pregnancy. Over to you, Danielle. Thank you so much.
Thanks very much, Helen. Can you confirm that I have shared my slides properly?
I can see that, yes.
Brilliant, thank you. So thanks very much, Helen, for the opportunity to talk today at the CRE HiPP Showcase. I am really excited to talk about the UK Preconception Partnership, which I joined last year as a postdoctoral researcher when I moved from Australia to Southampton in the UK. So I'll provide a brief overview of the partnership in terms of who we are and what we do to ultimately normalise, improve and measure preparation for pregnancy. So where did it all start for the UK Preconception Partnership? Back in 2016, a group of researchers from across the UK got together to discuss a vision and a way forward for research and for research translation in preconception health. This meeting informed the Lancet series on preconception health, with which many of you might be aware of. This was led by Professor Judith Stevenson at University College London and published in 2018. The first paper proposes definitions for preconception health in terms of the time frame, and it describes how well women of reproductive age adhere to guidelines for nutrition and lifestyle. The second paper then provides evidence on how this affects the lifelong health of women and men, and that of any children that they may have. And the last paper proposes a number of intervention approaches to improve people's nutrition and health behaviours across key stages during the preconception period. So based on the evidence presented in the Lancet series, this set of recommendations was developed to move from the evidence to policy and practice change. So just really briefly, recommendation 1 reflects the proposal for a dual intervention strategy to support individuals planning pregnancy and also to reduce wider determinants of preconception risks at a population level. The second recommendation is based on the framework to tailor interventions to people based on their life stage and motivation. For example, to start early through including preconception health in school curricula, as very nicely presented by Ruth, and later on perhaps through approaches in community and healthcare settings. The third recommendation is to use existing platforms where possible to integrate preconception care, deliver interventions and raise public awareness. And the last recommendation calls for advocacy coalitions to create collective demand for preconception interventions through continuing to build the scientific evidence, also through monitoring of progress made towards improving preconception health, and by working with relevant partners to develop interventions and campaigns. So to take these recommendations forward, the UK Preconception Partnership was established with the aim to develop and implement an action plan to improve preconception health and care in the UK. So to achieve this, the partnership, which is also chaired by Judith Stevenson, at the moment brings together over 60 members, including academics, clinicians and policymakers, who together have a broad expertise relevant to preconception health, as well as a number of organisations who are invested in improving preconception health in the UK. To say that the partnership is not currently funded, but members are involved in a range of projects to address preconception health through various approaches. So unfortunately, there won't be enough time to talk to you about all the different projects that are going on, but I'd like to tell a little bit more about the projects I'm currently leading, which relate to monitoring population level preconception health, as Jacqui mentioned, and also exploring how we can raise awareness in the community of the concept and importance of preparing for pregnancy. So the proposal to monitor population level preconception health was published by the partnership in 2019, with the goal to hold governments and other relevant agencies to account for delivering interventions to improve preconception health. This Lancet paper outlines a number of intervention approaches, such as normalising conversations about pregnancy intention during routine health visits, supporting healthcare providers to have these conversations and to then offer appropriate support and advice. As you can see in this table, these intervention approaches were mapped against core metrics that can be used to monitor improvements in pregnancy planning and pregnancy preparation. So to move forward from this proposal for national surveillance, we conducted a review of preconception guidelines and policy documents last year to inform what preconception indicators could be part of a surveillance system and through what data sources can they be monitored. So this review identified 66 specific indicators across the 12 domains that I've listed on the slide here, ranging from wider determinants of health to health behaviours, health conditions, but also environmental exposures and genetic risk. So we mapped each of these 66 indicators to existing population-based data sources in England and found that 65 of the 66 indicators were routinely recorded in at least one data source, including routine health data sets, cohort studies, and national surveys. So the only audit was whether women and men receive a preconception assessment and preconception care. So based on this overview of preconception indicators and relevant data sources, we are now analysing routine health data that we have access to so far in the partnership to create a first report card on preconception health in England. So the main data set that we are working with at the moment to create a picture of women's preconception health in England is the National Maternity Services data set, which includes data collected at the booking appointment for women who use maternity care through the National Health Service, which is nearly all pregnant women in England. So we are working with 1 year of data at the moment to start with, which includes just over 650,000 women who had their booking appointment between April 2018 and March 2019. So this is a snapshot of some of the data I'm analysing at the moment. So just a note that all figures are preliminary, unpublished data, but this example shows that most women don't start taking folic acid supplements before pregnancy, which we had before from Jacqui as well. About 1 in 5 women in England smoke when they enter pregnancy. Half of women have overweight or obesity. About 1 in 10 women enter pregnancy with a mental health disorder, and 1 in 5 with a physical health disorder that might impact their pregnancy. Other common pre-existing conditions and experiences that women enter pregnancy with are obstetric complications in a previous pregnancy and previous pregnancy loss in 25 and 37% of women who have previously been pregnant. So in addition to this overall picture, we are also looking at inequalities in these indicators to identify who would benefit most from preconception care and to inform strategies and resources. So there are a lot of figures on this slide, but the main point to show you is that in general, women living in the most deprived areas in England, as presented in the darkest bar at the bottom of each of these graphs, these women score worst on these preconception indicators compared with women living in the least deprived areas in the top lightest coloured bars. So while the pattern of results is similar for most of these indicators, differences by level of deprivation are most pronounced for preconception folic acid supplementation, smoking, obesity, and mental health problems. We're also looking at differences in these indicators by other socio-demographic characteristics, such as, for example, maternal age and ethnicity, and also by previous pregnancy, which I've included as another example to show you. So these graphs show in the lightest bars at the top women who have not been pregnant before. Then the middle bar includes women who have experienced pregnancy loss and have not had a live birth. And at the bottom in the darkest bar are women who have children and who may or may not have previously lost a pregnancy. So the pattern of results here shows that women who are pregnant for the first time generally score best on these indicators before women with previous pregnancy loss and women with a previous live birth. So this highlights that there may be scope to identify and support women who have previously lost a pregnancy, whom, if intending to become pregnant again after a loss, may be motivated to make changes that could improve their chances of becoming and staying pregnant and having a healthy baby. And similarly, identifying and addressing barriers to its optimizing health and well-being in women who already have 1 or more children is clearly needed based on these data. So at the moment, we have access to 1 year of maternity services data, but the idea is to produce these figures annually to monitor changes in the overall prevalence of the indicators, as well as changes in inequalities over time. So we are working closely together with the Department of Health and Social Care, who already have an existing public health surveillance platform. So they publish annual indicator data on a range of child and maternal health, as well as sexual and reproductive health indicators, such as, for example, the proportion of teenage mothers in England, which you can see in this graph has significantly declined over the past decade. So we're working together to prioritise a key set of preconception health indicators that can be added to this existing surveillance platform so that we can move from a cross-sectional picture of women's preconception health to look at trends over time to inform policy and practice priorities. To inform national surveillance further, in addition to using maternity services data, we're also planning to look at primary care data to determine which data sources can be best used for specific individual preconception indicators, and also to be able to report on preconception health in men, which has been mentioned before. Then to be able to see improvements in population level preconception health, we need to not only identify the need for interventions, but also co-develop strategies that are most relevant and appropriate to people of reproductive age. So to start these conversations with the community, as part of the Preconception Partnership, we have established a public engagement group of about 50 people of reproductive age. The first project that we have worked together on was to explore people's thoughts on appropriate language for public health messages and their ideas on strategies to raise awareness on the topic. A lot of interesting findings have come out of these discussions, which I'd love to tell you more about when I have more time. But just to say now that based on all these discussions that we have had, we've developed a set of language recommendations which will hopefully be published sometime next year. And so far, these have already contributed to improving the language and messages that are used in local social media campaigns called Ready for Pregnancy and Ready for Parenthood, and also an online poster with information on 7 key steps to take when thinking about having a baby. So this group of members of the public are really keen to continue to engage with our plans for research projects and dissemination of our findings. So it's really exciting, and we look forward to working to continue to work with them. Lastly, I would like to briefly mention the HiPP Earlier Mid-Career Researcher Collective, which Helen talked about before, which was formed by a group of Australian-based earlier mid-career researchers and mentors in 2019. So we are supported by CRE HiPP, and I just wanted to share that being a member has personally benefited me a lot through opportunities for collaboration, networking, career development, taking on leadership roles, mentoring. So if you are a PhD student or an early or mid-career researcher, and you're not a member yet, then please have a look at the website and get involved if you would like to connect with others working in the HiPP field. Last month, I also decided to see if we could establish a similar collective in the UK. And since spreading the word last month, we have already received almost 60 registrations from PhD students and earlier mid-career researchers, also clinicians and policymakers from across the UK, which is very exciting. And building on the Australian and UK-based networks, we aim to explore how we can develop a global HiPP EMRC network. So if you are interested in being involved in this initiative, or if you know of early or mid-career researchers or potential mentors in any country who may be interested in developing a global HiPP EMRC network, then please get in touch. And that leaves me to acknowledge some of my key colleagues. Sorry, Helen, just to say thank you to my key colleagues, as well as the broader Preconception Partnership and the HiPP EMRC for their support and contributions to the work I presented. Thank you, Helen.
Thank you, Danielle. It was a fantastic presentation. We've got a question for you before we go to Fionnuala Brilliant work, Danielle, from Adrian. Does the awareness, posters, etc., link to the TOMI UCL Are You Ready preconception campaign?
Yes, that's right. So they are all linked. So the poster that I listed on the slide, you can find it on the Contraception Choices website. So if you Google Contraception Choices, you'll find the website, and that will have that poster on it. It also links with TOMI's as well. They're two separate websites, but the information is all consistent. So we're all working together. So TOMI's is part of the UK Preconception Partnership as well. Yeah. Thanks, Adrian.
Thank you so much. So we have that was really, really good timing. So Danielle, thank you very much. Danielle, as you all might know, is a postdoctoral research fellow at the University of Southampton in the UK and has a background in nutritional and public health epidemiology. Really smart person, fabulous. Thank you so much, Danielle, for your presentation. Okay.
Thanks very much, Helen.
See ya. Bye. And now I have the great pleasure of introducing you all to our final keynote speaker for this CRE HiPP Showcase event, Professor Fionnuala McAuliffe. So Fionnuala, are you ready to share your screen? Might see if I need to help Fionnuala. There you go. We can see you now, Fionnuala. Can you hear us?
Yes, I can. Thank you.
Oh, terrific. Yes, we can hear you. Are you ready to share your screen?
Yes, I am.
Oh, terrific. So what we've been doing is we've been launching straight into the presentations, and then at the end, I'll come back to talk about you. But over to Fionnuala, who will be talking to us today about life course approach to improve maternal and infant health. And again, all the way from Ireland, Dublin, from the University College Dublin. So thank you so much, Fionnuala, because I know it's about 5:45 in the morning, isn't it?
It is. Thank you very much. And,
all right. Thank you.
Thank you so much for the very kind invitation to join. And I'm just checking if everybody can see my slides.
Yes, we can.
And you can hear me. Fantastic. Thank you. And well done again for putting such a fantastic program together. So I'm Professor Fionnuala McAuliffe from Dublin, and I'm going to talk to you about the life course approach. So increasingly people are focusing on a life course approach to the prevention and management of chronic disease. And what do we mean by the life course approach? Well, if a mother is entering pregnancy, as we've heard already, with high BMI, poor nutritional status, well then that puts her on a high risk trajectory for diabetes, obesity, hypertension, but also through fetal programming, her infant is also on a high risk trajectory for gestational age and other chronic illness. So really what we're trying to achieve with the life course approach, and particularly around preconception and early pregnancy care, is to reduce the mother from that high risk trajectory to a low risk trajectory. And of course, non-communicable diseases are the biggest global challenge today. I guess at the moment we feel it's COVID, but of course, non-communicable diseases are one of the biggest risk factors for morbidity and mortality from COVID. And globally, non-communicable diseases account for more than 70% of all deaths. And malnutrition is inextricably linked to NCDs and the risk factors. And up to 1 in 3 people around the world suffer from the effects of some form of malnutrition. I guess in Ireland and Australia, it's overnutrition, but also malnutrition in terms of micronutrient deficiency. So what are we trying to do with preparing families and couples for pregnancy? We want to focus on optimal weight. We would like to identify any nutritional deficiencies that require treatment, and also some specific medical disorders that require stabilization, including review of medications. So obesity affects 10 to 40% of adults, and you can see here that this is data from women and men of reproductive age, and certainly in Ireland the rates are around 20-25% of people of reproductive age having a BMI over 30, and you can see from this table here that this is quite common across many countries in the world. High weight impacts on pregnancy outcome, but of course, it's really the link with non-communicable diseases and chronic disease, both for the mother and the infant, that is a very significant factor. And really what we're trying to do is reducing the risk that the mother has non-communicable diseases, and also to pass that reduction of risk onto her child and their children. So maternal diet and body composition, we know, is influenced by glucose, by macro and micronutrient, and this has potential impacts on oocyte and embryo responses in terms of epigenetic modification, altered intracellular signaling, metabolic stress and apoptosis. And of course, during developmental plasticity, this can alter fetal growth, alter the setting of the neuroendocrine axis, leading to either high or low birth weight, leading to potential long-term consequences of stunting, impaired neurodevelopmental performance, obesity, cardiovascular and metabolic disorders. So I'm a member of the Pregnancy NCD Committee and just taken up a position of chair of the impact of pregnancy on long-term health. One of our initiatives in the last 2 years was the Figo Pregnancy, Obesity and Nutrition Initiative. So Figo is the International Federation of Gynecology Obstetrics, and we have 136 country members. Our vision is nutrition and weight at the front line of pregnancy care for women globally, and really a call to action for all healthcare providers thinking nutrition and weight first at every contact. And we have perhaps a very ambitious goal, but that's it, to give the gift of a life free from chronic disease. So together with Mark Hansen and Moshe Hod, we launched this initiative in 2020. Together with this, we produced a pony supplement, Pregnancy, Obesity and Nutrition Initiative, which covers 7 articles. It's free for download and was published last September in the International Journal of Gynecology Obstetrics. And there's a number of articles there, policy documents and practice guidelines. And of course, the obstetricians and gynecologists and all who look after women during pregnancy are uniquely positioned to influence maternal weight before and during pregnancy. And we need to look at weight before pregnancy and during pregnancy. And of course, there are many clinical guidelines for this, and we collated them together into one clear global guidance for the management of women living with obesity before, during and after pregnancy. So this is the guideline, and just to give you a brief snapshot, of course, today we're very much focused on pre-pregnancy, and really we need to think about weighing women and measuring their height and calculating their BMI, taking account of ethnic differences before pregnancy. And I guess if we see women before pregnancy, that gives us an opportunity to advise them and introduce interventions such as weight loss through diet and exercise, and where appropriate and if available, pharmacological medications and bariatric surgery. And of course, women with a higher BMI should be advised to take up to 5 milligrams of folic acid for at least 1 to 3 months prior to conception. There are also recommendations for the care of women living with obesity in pregnancy. And as you can imagine, they're quite detailed, including multidisciplinary care pathways. And then, of course, postnatal is a time that we can really interact with women. A lot of healthcare professionals find that they don't see women before pregnancy, but we can certainly use the post-pregnancy and inter-pregnancy interval as a time to review any pregnancy complications that may have developed, offer follow-up treatment such as glucose monitoring if she's had gestational diabetes, blood pressure monitoring if she's had preeclampsia, and of course use this as an opportunity to promote breastfeeding. Women with a higher BMI have more challenges with breastfeeding and have lower breastfeeding rates, and of course use this as an opportunity to consider a weight reduction in the postnatal period. So just a couple of words about breastfeeding, and what many of you may be familiar with this data, but I'm really excited with this data. This is looking at women who had gestational diabetes in pregnancy and looked at the chance that they developed type 2 diabetes in the 2 years following that pregnancy. And they looked at breastfeeding versus no breastfeeding, and they found that women that breastfed were half as likely to develop type 2 diabetes in the 2 years postpartum. So really strong effects there that breastfeeding can reduce the development of type 2 diabetes, which is a very significant chronic illness. And then looking at the dose response, they looked at women that breastfed just for 2 months compared with women that breastfed for longer. And they found that the longer the woman breastfed, the lower the reduction in type 2 diabetes. So this is sort of evidence that we can use breastfeeding advice not only to promote breastfeeding, to encourage bonding and to reduce childhood obesity, but also now to reduce the chance that she may develop type 2 diabetes if she's had gestational diabetes in pregnancy. So we're aware in Ireland as well that our women with higher BMI have lower breastfeeding. And we've recently, together with Charlene O'Reilly, who may be familiar with many of you, looked at barriers and enablers of women with a BMI over 30 who breastfed exclusively for 6 months. And there are physical challenges with breastfeeding with a higher BMI in terms of a larger breast size and potentially more difficulty in latching on. And of course, the women may be more concerned about breastfeeding in public because of body image. But looking at enablers, a supportive partner and lactation consultant and breastfeeding friendly networks were seen as strong enablers. And based on this, we've recently undertook a multi-centre trial to increase breastfeeding in women with a higher BMI of higher than 25. And you can see here that taking on the qualitative information, there are group sessions antenatally with the partner present during pregnancy to advise them of the important role they have in supporting breastfeeding, a one-to-one lactation consultant consultation in the hospital, and then follow-up online resources and drop-in clinics. And our primary outcome is breastfeeding at 3 months. So we're interested to see how this intervention works to increase breastfeeding in this at-risk group. Figo has also produced guidance on nutrition all across the life course, including adolescence and the adolescence period. And as you'd imagine, there are certain micronutrients that we need to focus on. Anemia is quite common, folate and calcium deficiency also. So we need to consider these micronutrients when planning a pregnancy. And of course, to identify and reduce and advise risky behaviours such as tobacco and environmental toxins. And of course, chronic disease screening and management is very important. So these are just some of the common nutritional deficiencies that are present in adolescent girls and women that may require supplementation. Those of us in the Northern Hemisphere, vitamin D, most of us are vitamin D deficient at this time of year, which is winter. But in many countries, there can be iron deficiency as well, and iron deficiency associated with menstruation. So in Figo, the Pregnancy NCD Committee, together with the Reproductive Endocrinology Committee, produced a joint position paper on preconception care. Of course, many women may attend fertility clinics, and it's to try and capture women before pregnancy. And really to consider the pre-existing conditions such as diabetes, polycystic ovarian syndrome and hypertension, and also the micronutrient deficiencies. And of course, we can advise women about appropriate exercise, at least 30 minutes of moderate exercise per day. And any woman who has any pre-existing chronic illness should be stabilised prior to pregnancy. Particular conditions that women may not even perceive as being risk conditions are polycystic ovarian syndrome. And of course, we know that this is associated with a significant cardiometabolic morbidities in the long term. So what about the partner? What evidence do we have that higher BMI affects partner fertility? Well, this is a systematic review looking at unselected men with obesity. There was no impact on sperm concentration and percentage of normal sperm morphology, though there was a decrease in semen volume, sperm number, percentage of forward progression, and percentage of viability. So this is evidence that obesity affects semen quality, and maintaining normal weight may be one of the effective ways to improve male fertility, as many of you may know is responsible for a third of cases of fertility issues. So what about evidence for intervention in women, in men with higher BMI and infertility? Well, this is a study, a small study, but well designed, looking at men with a higher BMI undergoing a bariatric surgery and being treated with IVF. And after bariatric surgery, there was increases seen in many of the parameters of semen health. And interestingly, there were evidence of improvements in IVF outcomes, number of top quality oocytes and fertilized oocytes. So the theory here is that a reduction in BMI results in epigenetic changes in the sperm. However, just a word of caution, as many of you may be aware, that of course after bariatric surgery there can be rapid weight loss, and there can be significant nutritional deficiencies and metabolic disturbances. So these need to be very carefully managed with micronutrient replacement, and certainly for women, the advice is to wait at least 6 months after bariatric surgery and when the weight is stabilized before embarking on a pregnancy. What other interventions can we consider? Well, probiotics. We recently did a systematic review of whether probiotics will improve metabolic health in healthy women of reproductive age, and we found no impact in healthy regular women. And in terms of fertility, we did a systematic review and actually found that probiotics may improve fertility in terms of improving the vaginal microbiome in the lactobacillus species. One study showed improved clinical pregnancy rates, and 2 studies showed improvement in sperm motility. So the details are there for those of you that are interested. So this is quite exciting, showing that potentially probiotics may help male fertility, with 2 studies showing an improvement and potential role for improvement in female fertility. So many healthcare professionals will say, look, I know that nutrition and weight are important, but where do I start? I don't feel equipped to counsel people about the nutritional status. So there are many different resources, but really many not focused perhaps on the setting of a busy antenatal or pre-pregnancy clinic. So in Figo, we produced the Figo Nutrition Checklist. So this is a 1-page that the woman by herself, whilst in the waiting room or with her healthcare professional, fills out, starting with identifying any special diets such as vegan or vegetarian, calculating the body mass index, and then really just going through the quality of the diet, very simple yes/no questions, and micronutrient status. So that's on one side of the Figo Nutrition Checklist, and then on the other side there's advice that the healthcare professional can give to the woman depending on the responses. So what do we know about the Figo Nutrition Checklist? Well, it's been translated into Italian and been shown to associate with early pregnancy outcomes, and also into Chinese, where it was compared with a standard validation tool of the food frequency questionnaire, and found that the simple checklist correlated quite well with the results from a food frequency questionnaire taken at the same time. Interestingly, in the Chinese study in Hong Kong, nearly 95% of women report at least one suboptimal dietary behaviour. We've also trialled it in Dublin, and we found that 80% of our women had at least one suboptimal dietary behaviour. So really quite common to have nutritional issues that need to be addressed. So I'd encourage you, all of you looking for a quick, simple nutritional tool, to consider downloading it from figo.org. It's currently in English, but please do translate it, as the other groups have, into your own language, and adapt to local dietary guidelines or diets. Another tool that we have developed is the Holistic app. So we've run a number of randomized trials in pregnancy. This was the PAIR study, where we randomized 565 women with a BMI over 25 to a low GI diet, physical activity, and supported by a smartphone app. And what did we find? We found that there was a less gestational weight gain, less large for gestational age infants, and better insulin sensitivity. And those that engaged with the app had better diet. And interestingly, then the women from lower socioeconomic groups found the app more useful than those from a higher socioeconomic group. So it seemed that we were potentially supporting a group that can be difficult to reach. So we've now translated this app into one that's now available. There are recipes, so it's all developed by a nutritional dietitian appropriate for pre-pregnancy and pregnancy, with recipes for breakfast, lunch and dinner, meeting the nutritional requirements that are required. And I'd encourage you all, it's free for download on the App Store or Google Play. So we launched it earlier this year, and we were very excited that 25% of all downloads are outside of Ireland. So this is something that it's validated through randomized controlled trial evidence. So many apps that we have wouldn't have that sort of scientific robustness behind it. So please do consider downloading it and recommending it to your pregnant women, which is free for download. So just to finish up then, really encouraging us all to think about the life course approach to prevention of chronic disease. Think about pre-pregnancy and pregnancy as crucial times to reduce a woman who potentially could be at high risk trajectory for herself to develop non-communicable diseases, and also putting her fetus potentially on a high risk trajectory, and see if we can reduce that high risk trajectory to a lower risk trajectory. So the life course approach is very important for maternal and infant health. And of course, pregnancy is a crucial time in the life course. By addressing nutrition and weight with women and men of reproductive age, global health outcomes can be improved and the burden on healthcare systems reduced. Diet, lifestyle and breastfeeding are the cornerstone of maternal nutrition and obesity management. And do consider the resources that we've developed, the Figo guidance, nutrition checklist and the holistic app. And let's all work together to give the gift of a life free from chronic disease. Thank you.
Thank you so much, Fionnuala. That was, and again, an excellent presentation. It's been a fantastic event today, and thank you so much for coming in at that very end and giving us such a superb presentation to finish on. Are there any questions that anyone would like to ask? I'll just see if anyone chats in the Q&A. I can see that someone has posted something. Fantastic. Well, this is just a comment, so it's a lovely comment. From Jenny Goris. Fantastic presentation, Fionnuala. I love the Figo nutrition checklist and holistic app.
Thank you.
It's terrific, isn't it? Jacqui, you've joined. Have you got any questions?
No, I really some of those resources though, and I agree, Fionnuala, that there's a lack of evidence-based apps, and really nice to see that one. Thanks.
Yeah, very important, isn't it? Any other questions from the audience? No, it looks like you were obviously so impressive, Fionnuala, that there are no questions. I'm sure people will be in touch if they do want to ask you anything, but thank you again so much for joining at such an early hour of the day. I'm sure you've got a very busy day ahead of yourself, so thank you so much. Everybody, let's thank Professor Fionnuala McAuliffe, who is a Professor of Obstetrics and Gynecology at National Maternity Hospital Dublin and the Head of Women's and Child's Health at University College Dublin and Director of the UCD Perinatal Research Centre, a multidisciplinary research centre aiming to improve outcomes for mothers and babies through clinically relevant pregnancy research. Thank you so much. We were honoured to have you today as our keynote speaker.
Well, thank you very much for the very kind invitation, and I very much enjoyed being here. Thank you.
Thank you. Thank you. And now we will hand over to Jacqui Boyle, who will close off the session with some concluding remarks. Thank you so much, Jacqui. Thank you everyone from me as well for attending. I really appreciate your support of CRE HiPP, as I said, right from the very outset. And we will be posting on the, there is a quick question, Fionnuala. Regarding breastfeeding, does Ireland have successful strategies increasing breastfeeding rates we can learn from?
Well, I think, you know, we have a long way to go in Ireland for breastfeeding. But I'd see there's the two key points really that I think are important. One is initiation. So really it's putting the baby to the breast on the labour ward before they leave the labour ward seems to be absolutely one of the key times. So and to, you know, to support that, once the baby's delivered, putting the baby on the chest, on the breast, the baby will then naturally start to move towards the breast. So that seems to be a really key time. Often women are overwhelmed after delivery, and they may be sore. They're, you know, it's such an incredible moment actually at the birth. So I think that seems to be really crucial, that initiation. And then the second key point is on discharge from hospital. So a lot of women may initiate, and then of course they may go home before the milk comes in, and they're at home, the baby's crying, they're distressed, and then somebody says, look, why don't you give a bottle or whatever? And I suppose that's where the partner comes in, because the partner doesn't want to see their partner distressed, struggling, and thinking, well, look, we can just offer a bottle and that'll, you know, everyone will be happier. And I think that's why the data that the qualitative data we found is that the partner's input. So we need the partner there to support her to breastfeed, rather than not knowing that this is normal when the breast milk comes in, etc. So that discharge from home is another key time to support there. So certainly those are the key points. And of course, anyone who's breastfed or has helped women breastfeeding, it's just that support of different positions and so on, and really giving the woman the confidence that she can continue. I guess the other initiative are the breastfeeding friendly hospitals, breastfeeding friendly communities. So one of my PhD students is a neonatologist, and she's looking at breastfeeding friendly indicators that could be applied to communities and cities to see, are they breastfeeding friendly. So I think, you know, the public and support is hugely important. What are your breastfeeding rates like in Australia?
Not very good. They're pretty poor, actually. The exclusive breastfeeding rates are very low. Yeah. So,
yeah,
even
I think a lot
even upon discharge, they're quite low. So there's a lot that we need to do. There's you know, huge campaigning, excellent researchers here in Australia who continuously advocate for it. But it is a very difficult uphill battle.
Yeah, I think it's also the culture, you know, breastfeeding friendly restaurants and
yes,
cafes, and you know, all of that. You know, there's no one thing really. The woman, once she leaves the hospital, needs to be supported by her community. So it's so that's interesting that that maybe we could work together to help both countries to improve.
Absolutely, I agree, Fionnuala. It would be terrific to keep talking about these cross-country questions and problems that we share, because we shouldn't be sharing them. It's 2021, you know. The rates should be much, much higher, but they're sadly, embarrassingly quite low. Thank you again, Fionnuala, and we appreciate your wisdom and your presentation today. Thank you so much. It was a real honour. So I'll hand over now to Jacqui to close the event officially. Thanks, Jacqui.
Thanks, Helen. I'd also just like to thank everyone for coming today, and everyone who's spoken today, and particularly our international speakers, because I know it was a very early start for you. We really appreciate it. I think one of the really key themes that's come out from today, it's probably no surprise to anyone, it's around the importance of preconception health for pregnancy, for the next generation, but also for the long-term health of the woman and for men, and in fact for all genders. It's highlighted that, you know, with the complexities, that we really need a multifaceted approach across the life course, and we probably need to think about how we can integrate well with existing services and resources. And I think that Professor McAuliffe highlighted that by, you know, having an opportunistic every time think about raising some of these things. And that certainly fits in with some of the other initiatives such as One Key Question and reproductive life plans. So I think people talked about a range of initiatives, so working with individuals and tailoring it at different phases across the life course and for when people are both intending and non-intending to have a pregnancy. And that we really need to start early. I think Ruth really highlighted the need to work with young people, and it kind of breaks my heart that we don't, you know, equip them well enough to embark out into the big wide world. And I think that's a real gap that hopefully we can address. There's obviously the population level and advocacy and monitoring, and I think Danielle really highlighted the importance of data, and we don't know what we don't know, so we have to make sure that we're collecting the right data and that we're monitoring the right data. And that's going to be particularly important if we're going to be looking at inequities in health and monitoring impacts of interventions and making sure that we're not exacerbating any disparities. Education and resources for everyone, for community, for health providers, for schools, for teachers. And I think we've seen a few outlined here today, which most of us will find quite helpful. So that's really good to hear. The importance of listening to the people that we're working with, I think, has really been highlighted. And I loved that Adrienne did all that work before she embarked on her research. Danielle's doing amazing work collecting consumer views all across the UK. And, you know, the voices of young people and teachers, I think that Ruth's highlighted, really brings, you know, the need forward and in a very personal way, which really reaches all of us, I think. So I think it also just highlights the collaborative, the way that we all have to work together as well. It really, if we look at that socio-ecological model, it really does require a broad collaborative approach. And I think we've seen quite a bit of that highlighted today, and just like to thank everyone again.
Thank you, Jacqui. Thank you, Jacqui, for leading the preconception health arm of CRE HiPP and doing so brilliantly. We are really pioneering innovations in generating new knowledge in the area, and thank you so much, Jacqui, and to your team and to all of the chief investigators and associate investigators and all the affiliates of CRE HiPP. Thank you once again. Goodbye, everyone. This is it. That was our CRE Showcase event for 2021. Hopefully in 2022, we will be live. We'll be able to meet up face to face. That'll be fantastic. So goodbye, everyone. Thank you. Bye.
Bye.